I am now starting the modules on renal disorders. The first topic is anomalies of renal system. When we talk about anomalies of renal system, we can divide them into renal parenchymal anomalies, which basically refers to problems in the upper part of the urinary tract. Then you can also have distal urinary tract anomalies, which basically refers to the problems in the bladder and urethra. Okay, first I will start with the renal parenchymal anomalies. We can divide this renal parenchymal anomalies broadly into few categories. One is the renal agenesis. As we all know, genesis means development, a means absence of development of the kidney. Second is dysplasia. Basically, dysplasia is a histological term which is characterized by presence of primitive structures in the kidney, and that too ductal structures, primitive ductal structures in the kidney. This usually results from abnormal metanephric differentiation. So some problem during development of the kidney results in abnormal structures present in the kidney. That is what is called as dysplasia. Okay, and third type of parenchymal anomalies is something called as a fusion defects. Okay, a typical example of this is horseshoe kidney, where there is fusion of both the kidneys. I am going to explain all these conditions in detail. First topic would be dysplastic disorders of the kidney. As I said, dysplasia is a condition characterized by abnormal primitive structures in the kidney, and these structures result in the formation of cyst inside the kidney. So this condition will be called cystic dysplasia. Okay, and these conditions causing cystic dysplasia can either be unilateral conditions or bilateral conditions. Please remember, unilateral conditions are more common compared to bilateral conditions. We'll start with the first condition associated with cystic dysplasia, and that is a unilateral condition, also called as a unilateral renal dysplasia. The main name of this disorder is called as MCDK, which is an expansion for multicystic dysplastic kidney. That is the main name of this condition. The other name is unilateral renal dysplasia. Okay, as the name itself suggests, it is a dysplastic condition characterized by formation of cyst inside the kidney, and it is unilateral condition, usually more common on the left side. Okay, right. As the name suggests, this condition is characterized by multicystic dysplasia. What is the meaning? There is lot of cyst present inside the kidney, and this multiple cyst can even replace the normal kidney tissue. So if I ask you the question, what happens to the function of the affected kidney? The function is completely abnormal, or in other words, there is no function of the kidney because all the kidney tissue is replaced by the cystic mass. So the renal function on the affected side is absent. Okay, right. Now, what is the problem because of this? Remember, this is a unilateral condition. Always remember this rule in kidneys: whenever only one side kidney is affected, the other side kidney, that is a contralateral kidney, which is normal kidney, can undergo hypertrophy. Are you able to follow this? So because of hypertrophy, it takes up the extra function of the affected kidney also. So overall, if you see the renal function in these patients, it is normal. That is, if you calculate the glomerular filtration rate or the levels of serum creatinine, everything would be normal because the unaffected kidney has undergone hypertrophy, and this will do more function to compensate for the affected kidney on the other side. Very simple. Okay, so remember, the function of the affected kidney is absent, but overall renal function is normal due to hypertrophy of the other normal kidney, right? Okay, now coming to the point, how do these children present with, or what is the feature of this particular condition? Remember, on the affected side, I told you there is a lot of cyst. This cyst will result in enlargement of that particular kidney. So how does it show up? It shows up as an abdominal mass. You will have a abdominal mass as the presentation. Which area is this abdominal mass present? It is in the loin region. That is the region of kidney, and that is where you will have the abdominal mass. Okay. The child will be otherwise asymptomatic, except for the abdominal mass. Child is otherwise asymptomatic. And this is an important MCQ question, that MCDK is the most common cause of palpable abdominal mass in a newborn. And another important one-liner is MCDK is the most common cystic disorder of the kidney. These are two important one-liners commonly asked in your exam, which you should make a note of. So what is the natural history of this MCDK? The cyst will undergo spontaneous involution or regression by the age of 5 to 7 years of age. Generally around 7 years, they undergo spontaneous regression or involution. However, remember, even though the cyst will regress, the function will not come back to normal, because already the normal tissue is replaced by the cyst. So function of that affected kidney will not be normal. However, the cyst will undergo spontaneous involution by 5 to 7 years of age. So as such, because the overall renal function is normal in these children, there is no need for any specific intervention, and these children are also otherwise asymptomatic. That is about the first condition of MCDK. Remember, I told you MCDK is an example of unilateral renal dysplasia. Now coming to the condition which is characterized by bilateral renal dysplasia or bilateral cystic dysplasia, and that condition is ARPKD. What is that? It is autosomal recessive polycystic kidney disease. Now, this should be differentiated from another condition called autosomal dominant polycystic kidney disease, which usually presents in the adult age group. Right now, in pediatrics, we discuss about autosomal recessive form. And this condition is due to a defect in a gene called PKHD1 gene, located on the short arm of chromosome number 6. So it is 6p, which is the location of PKHD1 gene. This gene codes for a protein called fibrocystin. So as you can infer from the name, in this particular condition, because the protein which is going to be associated is fibrocystin, you will have presence of fibrosis, along with that cyst formation inside the kidney. Okay, and please remember the name correctly, PKHD1. Here P stands for polycystic, K for kidney, and D for disease. What does this H represent? H represents hepatic. So in this particular condition, in addition to kidney getting affected, liver is also getting affected. Okay, so liver and kidney are two important organs affected in case of ARPKD. Let us first see what are the manifestations in the kidney. Renal manifestations. Remember, both the kidneys are affected in this condition. It's a bilateral condition characterized by cyst inside both the kidneys. Okay, now please remember, as I told before, whenever there is lot of cyst present inside the kidney, it will result in enlargement of the kidney. So this condition can also present with abdominal mass, but here it will be bilateral abdominal mass. Which area? Again, it is a loin area. Okay, right. Next is the cyst can compress the normal renal parenchyma. Okay, So what happens when they compress the normal renal parenchyma, the functioning of the kidney will be affected. Remember, this is a bilateral condition, so both the kidney function would be decreased, or in other words, the overall renal function is also going to be decreased. Okay, right. In fact, you should remember that most of these children, they develop ESRD, that is end stage renal disease, by the time they reach the school. So school age children affected by this condition usually develop end stage renal disease, and they are dependent on either dialysis or renal transplantation for the survival. Okay, right. Third important manifestation of this bilateral cyst is that they can also compress the renal blood vessels when they enter into the kidney. So because of compression of the blood vessels, it can result in ischemia due to decreased blood flowing into the kidney. And whenever there is ischemia in the kidney, there will be release of renin. And we all know that renin is going to activate RAS. What is that? Renin, angiotensin, aldosterone system. And this would result in increased levels of aldosterone, and that would in turn increase the blood pressure. So these children also have hypertension. Okay, so these are the characteristic renal manifestation due to autosomal recessive PKD, which includes bilateral renal enlargement, decline in renal function leading to end-stage renal disease, and finally hypertension. Okay, right. Now, next set of manifestations are related to the liver. Okay, in the liver also they are associated with the formation of cyst as well as fibrosis. Okay, now fibrosis ultimately would result in what problem in the liver? Yes, it is going to result in cirrhosis of the liver. So these children also develop liver failure due to cirrhosis, or chronic liver disease due to cirrhosis. So if you look at the management of this particular condition, it is primarily supportive. Okay, the only way by which these children can survive is a dual transplantation. Dual transplantation refers to transplantation of both liver and kidney. So this condition definitely is a difficult condition to treat, because dual transplantation is not usually possible in all these children. So they don't have a good outcome. Now, one point in this radiological investigation is regarding ultrasound appearance in case of autosomal recessive polycystic kidney disease. Have a look at this picture. You can see in this ultrasound that the echogenicity of the kidney is increased, or what we call as hyperechoic kidneys. Okay, that is number one. And number two, you are not able to make a clean distinction between cortex and medulla of the kidney. This is what is called as absence of cortico-medullary differentiation. These are some important radiological one-liner questions which can be asked with autosomal recessive polycystic kidney disease. So with that, I have discussed about the cystic kidney disorders. With that, I have discussed about dysplastic disorders of the kidney. Next, moving on to the section of agenesis of the kidney. You should also know that in severe forms of autosomal recessive polycystic kidney disease, the problems can start from the in utero period, wherein both the kidneys of the fetus becomes dysfunctional or non-functional. So what happens? This results in a set of problem called as Porter's syndrome. I am going to explain what is Porter's syndrome in detail. Before going to this topic, you should also remember another set of anomalies can also result in Porter's syndrome, and that is bilateral renal agenesis. Why? Because in bilateral renal agenesis also, the kidneys are not functioning, so the problems will start in utero itself. So what is this Porter's syndrome, which we are going to discuss in detail? So what is this Porter's syndrome? Let's see further. As I said, in this condition, there is problems in both the kidneys starting from the intrauterine life itself. So imagine like this, both the kidneys are not functioning in the intrauterine life. So what happened? There is no urine output from the fetal kidneys. Okay. Always remember this. The urine from the fetal kidneys contributes to amniotic fluid. So what happens if there is no urine output? It would result in severe oligohydramnios. Because of severe oligohydramnios or decrease in the amniotic fluid, there is compression of the fetus by the amniotic sac. So fetal compression would occur. And the problems which occur due to fetal compression is what we call it as Potter syndrome. Now, in this Potter syndrome, some important features are noted. First is starting from the face of the baby, and this is called as a Potter's facies. Okay, let us see what are the important characteristics of Potter's facies. You can see the first thing is regarding the eyes. You can notice that there is some fold of skin separating the eye and the nose, which is epicanthal folds. And this is also one of the reasons the eyes will look like widely separated eyes. Second thing, if you look at the nose region, the nose appears to be broad as well as flat. Can you notice the flatness of the nose from the lateral side? It's a flat and a broad nose, something like parrot beak appearance. What else can you see? Please notice in the ears. You can see that the ears are very, very low lying or low set ears. Okay, right. And the next important point to note is that this appearance wherein the chin is pushed backwards and it is also small. So it's a small chin, or what we also call as a receding chin. Okay. And also you can notice this very characteristic finding wherein you have lot of wrinkles in the skin. Lot of skin wrinkles. These are the characteristic facial features which is collectively referred to as Potter facies. What is the next set of problem? Think like compression of the fetus. As a part of it, the thorax is also getting compressed. So what happened? The lungs cannot properly expand inside the thorax. This results in pulmonary hypoplasia. And please remember, if the pulmonary hypoplasia is going to be severe, this results in death of the baby soon after birth. So that is why most cases of Potter syndrome are not compatible with life. The reason for death is severe pulmonary hypoplasia. A third important problem is that the limbs are not developing properly and the movements of the limbs is also severely restricted because of fetal compression. This results in limb abnormalities. The classical example of a limb abnormality in this condition is CTEV, which is the congenital talipes equinovarus. So facial abnormalities are there, lung abnormalities are there, and limb abnormalities are there. A collection of all this is what we call it as a Potter's syndrome. Please don't forget that any condition which results in non-functional or dysfunctional kidneys in utero can result in Potter syndrome. The typical examples are bilateral renal agenesis and severe forms of autosomal recessive polycystic kidney disease. I have said that bilateral renal agenesis is a severe condition and can result in Potter syndrome and death of the baby. However, unilateral renal agenesis is a less severe condition in the sense that if the other kidney is normal, as I said before, that normal kidney can undergo hypertrophy and ultimately the renal function remains normal. And also note that unilateral renal agenesis is more common compared to bilateral renal agenesis. If you look at the incidence of these defects, unilateral renal agenesis occurs in 1 in 1000 cases of live birth, whereas bilateral renal agenesis is relatively rarer. It occurs in 1 in 3000 cases. Okay, the importance of unilateral renal agenesis is that this anomaly can occur in association with other anomalies also. So if this anomaly is detected, you should always look for any other associated anomalies. And this association is remembered as Vacteral syndrome. Vacteral is an expansion which stands for V, vertebral defects, A for anorectal malformations like anal atresia, C for cardiac defects, TE is for the tracheo-esophageal fistula, or what is remembered in the short form as TEF, R for renal anomalies, and L for limb anomalies. This is the classical Vacteral association. Another important association of unilateral renal agenesis is it is associated with single umbilical artery. Always remember this, umbilical cord contains two arteries and one vein. So instead of two arteries, if you get only one artery, it is called single umbilical artery. And this is one of the common anomalies of the umbilical cord. And the importance of finding this anomaly is that you have to search for an underlying renal anomaly. These are the important points regarding unilateral renal agenesis. Next set of anomaly is related to renal fusion anomalies. This is a condition which is typically remembered as horseshoe kidney, wherein both the lower poles of the kidney are fused in the midline. Okay. And this fused portion is what is called as isthmus. Okay, this is an important question. What is isthmus? Is the fused portion in horseshoe kidney. Okay, now this condition is relatively more common compared to the other anomalies I have discussed. This usually occurs in 1 in 400 to 500 live birth. So this is a relatively common condition. Okay. And please know an important genetic association of this particular condition. It is associated with the Turner syndrome. Please note around 30% case of Turner syndrome are associated with horseshoe kidney. Now, the best way to find out the horseshoe kidney is by the imaging studies, where you can see the classical outline of the horseshoe kidney. Okay, right? And this in the center is what is called as a isthmus, which is the fused portion of both the kidneys. Now, horseshoe kidney is a relatively common anomaly. As such, the renal function usually remains normal. However, there are certain complications which can be associated with horseshoe kidney. What are the complications? Number one, if this is the kidney which is going to be fused like this. Now what you should notice, sometimes these ureters, they become obstructed due to that connections between two kidneys. So this can predispose to urethral obstruction. Okay. Whenever there is urethral obstruction, the flow of urine is affected, and this results in retention of the urine within the kidney itself. What is the name of that condition? Hydronephrosis. And second important feature is, when the urine flow becomes obstructed, there is stasis of urine, resulting in increased risk of renal stones. Okay, that's an important complication. Now, in the long run, these children can also develop recurrent urinary tract infection. Again, resulting from stasis of urine due to obstruction. Okay, and a final important point is, children with horseshoe kidney are at increased risk of Wilms tumor, which is a tumor of the kidney, in comparison to general population. Please remember, the risk of Wilms tumor is 4 times more in horseshoe kidney when compared to a normal kidney. These are the important complications associated with horseshoe kidney that one should remember. So always remember, these children should be kept under long-term follow-up. So what I have discussed in this initial set of anomalies are the renal parenchymal anomalies, which included the dysplasia, which we discuss further, next agenesis, and finally about the fusion defects. Now, moving on to the next set of anomalies, which involves anomalies in the distal urinary tract. This commonly refers to anomalies outside the kidney, which may be in the ureter, bladder, as well as the urethra. Okay, right. The first set of anomalies are associated with a condition called as obstructive uropathy. Very simple, they cause obstruction to the flow of urine. Okay. Now, before discussing what are the conditions which leads to obstructive uropathy, I will tell you about the common clinical features as well as the common investigation which we are supposed to do in these cases. The common clinical features, as I have discussed, accumulation of urine inside the kidney itself due to obstruction. And what is that? It is hydronephrosis. Yes. And because of hydronephrosis, there is swelling in the kidney region, right? This presents as enlargement of the kidney, which is usually presenting as an abdominal mass. Okay. Now please remember, hydronephrosis is the second most common cause of abdominal mass in a newborn baby. Very, very important point. Why this is important? Because the most common cause of abdominal mass in a newborn, I have already said, it is multicystic dysplastic kidney. Here, hydronephrosis is the second most common cause. Now please remember that hydronephrosis, if it is severe, it can also present as antenatal hydronephrosis. Okay. So even in the antenatal scanning also, you can notice that there is hydronephrosis in the fetal kidney. Okay. So first set of presentation is related to hydronephrosis. Second thing, whenever there is a swelling of the kidney, there is distension of the renal capsule, and older children can present with abdominal pain also. Which area they have pain? Yes, that is the area of the kidney. What is that? Yes, they have it in the loin region. Okay. Third important set of problem is related to stasis of urine due to obstruction, and this can predispose to recurrent urinary tract infection. Okay, right. And fourth important point is, because of obstruction to the flow of urine, there is poor urine stream. Also remember, whenever there is a obstruction to flow of urine, there is stasis of the urine, and this increases the risk of renal stones. These are the typical set of problems associated with obstructive uropathy. How to diagnose obstructive uropathy, or what are the investigations which are done in the antenatal period? You can do ultrasound. Okay, typically the second trimester ultrasound usually picks up most cases of antenatal hydronephrosis. Postnatally, after birth of the baby, you can do a radiological investigation called as MCU, which is micturating cystourethrogram. Okay. This is one investigation which can identify many causes of obstructive uropathy postnatally. You can also do ultrasound of the kidney, ureter, and the bladder, which is remembered as KUB. That can also find out anomalies predisposing to obstructive uropathy. So these are the clinical presentation and investigation of obstructive uropathy. Now I am going to tell you about certain important causes of obstructive uropathy. First is the most common cause, which is called as UPJ obstruction, or what is also called uretero-pelvic junction obstruction. Okay, that is called as UPJ obstruction. Let us see some important points about this UPJ obstruction. Please note, this is the overall most common condition. You can see that this is the picture of UPJ obstruction. This is the uretero-pelvic junction, which is becoming narrowed or obstructed. Okay, right. Now, the reason for this UPJ obstruction is not definitely known. It is an anomaly which is usually believed to be due to some abnormalities of smooth muscles in that region, which undergo unusual constriction, thereby causing narrowing, or it could be due to presence of fibrous bands that can also be associated with narrowing and obstruction at that region. Okay, right. Now, please remember that this condition is usually unilateral and more common on the left side compared to the right side. Okay. Another important point is the presentation is usually with antenatal hydronephrosis. Okay. And postnatally, it can present with the abdominal mass. Of course, in the loin region only, it presents as an abdominal mass. Okay. And the next one is a relatively rare presentation which can be noted in older children, where they present with recurrent episodes of abdominal pain, same area, loin area abdominal pain, along with episodes of vomiting. And this is what is called as the dietal crisis. Please remember, this is not a usual presentation. Only in older children, if at all, they present like this. However, from the exam point of view, it's an important question. So that's why you should know this term of dietal's crisis. Okay, let us see how we are going to manage these children after birth. Please remember an important point that most cases of uretero-pelvic junction obstruction, they resolve spontaneously after birth. Okay, usually around 48 to 72 hours after birth, they resolve. So what we do after birth, 48 to 72 hours later, we will take an ultrasound. Most of the cases would have resolved. Okay, right? However, some cases, even after this 48 to 72 hours, there would be persistence of UPJ obstruction, or in other words, it would be an unresolved case. Unresolved cases require surgical correction, and this surgical correction is by repair of that area, what we call it as pyeloplasty. Okay, the complete name of this is Anderson-Haynes pyeloplasty. This is the complete name of the procedure used for treatment of UPJ obstruction. That is the first condition associated with obstructive uropathy. Second is a more severe condition, usually noted only in males. That goes by the name of PUV, or posterior urethral valves. This is a severe condition. Okay, so if the question is asking you what is the most common severe cause of obstructive uropathy, especially in males, then your answer is going to be posterior urethral valve. Now let us see some salient points about posterior urethral valve in children. So as the name suggests, these are valves which are something like tissue leaflets. Okay, and this valves or the leaflets are causing obstruction to the flow of urine. As I said before, they are exclusively occurring in males and they cause a severe type of obstruction. You should know what is the location of these valves. It is in the lower part of prostatic urethra. Okay, this is the usual location and it is located just distal or just below to veromontanum. And these are the tissue leaflets, as I said before, and these tissue leaflet extend from the prostatic urethra till the level of external urethral sphincter. This is the classical location of the posterior urethral valve. So what is going to happen if there is an obstruction? These are the effects. This is the prostatic urethra and this is the location of the valves. Okay, so that area is getting obstructed. So what happened? The areas proximal to that obstruction will become dilated. So you can see that this part of the prostatic urethra above the valve will become dilated. So this is dilated part of the prostatic urethra. the bladder will become dilated, and you can see the wall of the bladder shows some abnormal contour, which is called as a trabeculations of the bladder. This is secondary to abnormal dilatation of the bladder. Okay. Third important is that the ureter becomes dilated, as well as the kidneys are also dilated. This is what we call it as hydroureteronephrosis. Okay. These are the consequences of the posterior urethral valve. Now, what are the typical presentation? Because of the hydroureteronephrosis, they can present with abdominal mass. Because of poor urinary stream, they can present with dribbling of urine during micturition, or the mother can tell you that when the boy is passing urine, it is a poor urinary stream. And because of stasis due to obstruction, there is also increased risk of urinary tract infection. Okay, right. These are the characteristic features of the prostatic urethral valves. How do you make a diagnosis of this condition? It is with the help of micturating cystoureterogram, which is remembered in the short form of MCU, or the other name of this is VCUG, which is nothing but voiding cystoureterogram. Can you notice in this particular condition, this is the site of defect. That is why above that area, all the structures are becoming dilated. So what happened? This is the dilated urethra, and above that is the dilated bladder here. Okay, very classical MCU finding of posterior urethral valve. Now, having diagnosed this condition with MCU, what is the management of this condition? Remember, first and foremost thing in these patients is to relieve the obstruction. Okay, it is typically achieved by inserting a feeding tube or a feeding catheter, which is nothing but a small polythene tube, which is usually of the size, French size 5 or 8. That is a usual small feeding tube which is inserted for catheterization to relieve the urinary obstruction. Remember, the usual way of catheterization is by the Foley's catheter. That should not be used in young children because the Foley's or the balloon catheter can result in spasm of the bladder and consequences because of that. So Foley's catheter is avoided while catheterizing a small baby. Okay, right. So after you have relieved the obstruction, you have to check for the serum creatinine. If the serum creatinine is normal, then you can go for the definitive treatment, which is destruction of the valves. And this is done endoscopically. So this procedure is called as endoscopic fulguration of the valves. Okay, this is the definitive treatment of choice in case of posterior urethral valve. Okay, suppose even after relieving the obstruction, the serum creatinine level remains elevated, then you can go for a temporary procedure in the form of vesicostomy. And after doing this procedure, you wait for the serum creatinine levels to become normal. Once the serum creatinine levels becomes normal, then again you have to go for the definitive treatment, that is endoscopic fulguration. The most important point to note is endoscopic fulguration can only be done after the serum creatinine level becomes normalized. That is about the second condition of obstructive uropathy, which is posterior urethral valves. The next condition is associated with a severe bladder malformation, which is called as ectopia vesicae or bladder extrophy. Okay. Ectopia refers to a different location. Vesicae refers to bladder. Bladder extrophy means bladder which is getting exposed outside. Or in other words, bladder is not in the usual position of inside the abdomen. It is getting exposed to outside. That is what is called bladder extrophy or ectopia vesicae. Please look at this picture to understand it further. Can you notice in this picture the fleshy mass like this, which is extending outside? That is actually the bladder which is coming out. That is a typical picture of ectopia vesicae. Okay. Now, this particular condition is usually associated with other malformations which include cryptorchidism or undescended testis. Next is epispadias, and third important finding is a split pelvis. These are three important associated findings in bladder extrophy. In severe cases of bladder extrophy, what happens is that in addition to bladder, the other structures like this structure, what is this? That is the ileum, is also getting exposed outside. Okay, and this combination of ileum getting exposed outside along with the bladder getting exposed outside, it's a severe form called as cloacal extrophy. Okay, and the name given for this condition is that it looks like that of a elephant trunk. Okay, can you notice this shape which looks like that of the elephant trunk? So it is also called as a elephant trunk ileum. That's a classical name associated with cloacal extrophy, which is elephant trunk ileum. Okay, so those are the important features of bladder extrophy and cloacal extrophy. And the last condition which is associated with obstructive uropathy in children is Eagle-Barrett syndrome, or also called as a prune belly syndrome. This is a condition which occurs from deficiency or deficient abdominal wall muscles. Okay, deficient abdominal wall muscles. And this results in the appearance of a skin of the abdomen which is wrinkled, and that looks like that of a prune. So that is why this is called as prune belly syndrome. Have a look at this picture. Can you see that the abdomen is very lax and it is distended and shows lot of this folds like this, okay, or wrinkles like this? It appears like that of a prune. That is why it is called as a prune belly syndrome. And this particular condition is associated with other set of anomalies also, which include cryptorchidism as well as dilated ureter and bladder. Okay, which is also called as a mega ureter and mega bladder. So what is this condition basically? It is deficiency of abdominal muscles resulting in a distended appearance which is looking like that of a prune. Second is cryptorchidism, and third is dilated ureter or bladder. This is the triad of prune belly syndrome, and because of this triad, this condition gets its name as triad syndrome. Okay, so what are the other names of this condition? Prune belly syndrome, Eagle-Barrett syndrome, or triad syndrome. These are the important anomalies which are associated with obstructive uropathy in children. Next is an anomaly which is associated with something called as reflex nephropathy. What is this reflex nephropathy? It's a condition wherein the kidney is damaged due to reflex. And what is that reflex which we are talking about? It is vesico-ureteric reflex. Now let us understand vesico-ureteric reflex, and then I will come to the discussion of reflex nephropathy. So what happens here is the reflex occurs from vesico to the ureter. Vesico means what? Bladder. From the bladder to the ureter, there is reflex. That is what is called as a vesico-ureteric reflex. Is this a normal phenomenon? Absolutely no, because from the bladder, the urine should flow into urethra and not into ureter. So this condition is a pathological condition where there is a backflow of urine from the bladder into the ureter. Let us see why this is going to happen. For this, understanding of normal anatomy is important. You can look at this picture where I have put up the normal appearance of the ureter at the time of insertion into the bladder. Remember, this is the full bladder. I have just taken one section. This is the full bladder. Please remember like this. This is the mucosa of the bladder, and this is the submucosal area, and inside is the musculature, the smooth muscle or the detrusor muscle. So think like that. Now what happens once the ureter enters into the bladder? this portion of the ureter is called as the intravesical portion of the ureter. Okay. Now, carefully notice the intravesical portion. It is not just like that coming and inserting into the ureter. It goes into the ureter, becomes narrow and oblique. Okay, it becomes narrow and oblique. Not only that, there is a submucosal tunnel of the ureter. Okay, or in other words, it runs like a tunnel in the submucosal portion of the bladder. Okay, and this intravesical tunnel portion of the ureter and oblique insertion of the ureter is responsible for the prevention of reflux during micturition. Okay, right? So to put it simply, it is because of the submucosal tunnel only normally reflux does not occur from the bladder into the ureter. Now, what happens in vesico-ureteric reflex, which is seen on the other side? First of all, you can notice that there is no oblique insertion. Okay, there is no oblique insertion of the ureter into the bladder. Second thing, you can notice that the submucosal tunnel is very, very small or short. Short or small submucosal tunnel. Okay, now, because of these two reasons, whenever there is micturition or contraction of the bladder, what will happen? The urine will flow back from the bladder into the ureter. Or in other words, this is the reason for reflux to occur in case of vesico-ureteric reflex. Okay, so this is the basic pathology in case of vesico-ureteric reflex that one should know about. Right, it is usually occurring as an anomaly, but can be inherited also, and the usual mode of inheritance is in an autosomal dominant manner. Okay, so that is about the introduction to vesico-ureteric reflex. As I said, it's an autosomal dominant condition, and second, it is more common in females when compared to males. In comparison, remember, posterior urethral valve is always occurring only in males, whereas VUR is more common in females. And this is a very, very important point. What will happen if there is a vesico-ureteric reflex? In vesico-ureteric reflex, what happens? There is a retrograde flow of urine from the bladder into the ureter. Okay, this predisposes the patient to develop recurrent urinary tract infection. Okay, and please note for your exam, the most common anomaly associated with recurrent UTI is vesico-ureteric reflex. This is a very, very important point. Okay, right. And second important consequence is, in case of high grade vesico-ureteric reflex, there is a retrograde flow all the way into the renal parenchyma itself. This results in renal scarring, and because of renal scarring, it can result in decreased renal function, also called as renal insufficiency, which can even lead on to chronic kidney disease also. Second, renal scarring also predisposes to the development of hypertension. This type of renal problems occurring due to vesico-ureteric reflex is what we call it as reflex nephropathy. Okay, right. So these are the important consequences of vesico-ureteric reflex. How to diagnose vesico-ureteric reflex? Again, the investigation of choice is micturating cystourethrogram or voiding cystourethrogram. This is the typical picture of micturating cystourethrogram demonstrating the vesico-ureteric reflex. Can you see classically this is the bladder region. From the bladder, that contrast is flowing back into the ureter. This is what we call it as vesico-ureteric reflex, and that is the investigation of choice to diagnose this particular condition. Next, based on micturating cystourethrogram, we can also do grading of vesico-ureteric reflex. You can see that basically there are 5 grades of vesico-ureteric reflex. Okay, in grade 1, the reflex is happening to this level. That means it is not extending to the full portion of the ureter, what you call it as partial reflex. Okay. The second important grade is where reflex is occurring to the full portion of the ureter. We call it as a complete reflex. In the third grade, you can see that there is some dilatation of the ureter as well. Okay, so third grade means complete reflex. Along with that, there is dilated ureter. What is grade 4 then? Can you see some unusual bending of the ureter as it goes along? What is that? It is tortuosity of the ureter. And in grade 5, can you notice that this reflexed material is entering into the renal parenchyma itself? So this condition is associated with the increased risk of renal scarring also. And how it is typically identified on the MCU? There is distortion of the renal pelvicalical impressions. Okay. So the simple meaning is that the reflex is occurring so severe that it goes through the pelvicalical areas and enters into the renal parenchyma, thereby causing distortion of the impressions at pelvicalical system. Okay. So these are the 5 grades of vesico-ureteral reflex. This grading is done with the help of micturating cystourethrogram. Now, what is the treatment of vesico-ureteral reflex? Remember, VUR is a condition which will improve with the age. That means this condition can undergo spontaneous resolution after birth. So, naturally, the point to be known is you need not actively treat this condition in the first place. However, till the time the VUR is going to resolve, there is always a risk of recurrent urinary tract infection occurring in this child. So, we have to prevent that by giving antibiotic prophylaxis. Antibiotic prophylaxis is usually given as a single time, that is only one time in a day, and usually given as a bedtime dosage. Right? It is not unlike the usual treatment where you give 2 times to 3 times daily antibiotics. It is just only one time a day, and that too at the night time before going to bed. And the common drugs which are used are cephalexin in a child less than 6 months old, and in a child more than 6 months, you can use trimethoprim sulfamethoxazole combination, okay, which is basically cotrimoxazole, or you can also use nitrofurantoin. Why not these drugs in a child less than 6 months? Because cotrimoxazole and nitrofurantoin can be associated with increased risk of hemolysis in this age group. So that is why they are avoided in children less than 6 months. How long is the duration antibiotic prophylaxis? That depends on the grade of vesico-ureteral reflex. For grade 1 or 2, it is recommended that you give antibiotic prophylaxis till the child is 1 year. Because most of these reflexes of low grade, they resolve within 1 year. So that's why till 1 year you can give. But other grades like 3, 4 and 5, you have to give till the age of 5 years, because it takes longer time for resolution of reflex in higher grades. Very simple concept. Okay. So you give antibiotic prophylaxis. At any point of time, if the antibiotic prophylaxis fails, meaning a child develops UTI in spite of giving antibiotic prophylaxis, which is also called as a breakthrough UTI, then it is an indication for surgical correction of vesico-ureteric reflex. Okay. And what is the usual surgical treatment? It is nothing but re-implantation of ureter into the bladder. Okay, right? So basically, you try to insert the ureter into the bladder in an oblique way such that the reflex is getting prevented. That is the usual surgical treatment in case antibiotic prophylaxis fails. That is about the discussion of condition vesicoureteric reflex. With that, we complete the discussion of congenital anomalies of the renal system.